now I'm going to ask Dr. NAIR, who's going to be talking in OCT, multimodal imaging of macular diseases.
Change of pace over here. We're just going to go a little bit into the medical management and a few OCT features in a very simple presentation. So we call it the 10 Commandments, okay? So the first, we're going to say that kindly realize, thou shalt realize that autofluorescence is a very powerful tool. And how do you know that? We use it for geographic atrophy progression, diagnosis, and progression over years. There are many things to look at, including the hyperautofluorescence areas, the progression, the shape, the edge of the autofluorescent black. So if you have a curved, round, circular edge, it means it's less advancing. If you have a scalloped edge, it means it's a faster advancing edge. So the use of autofluorescence. Again, in CSR, we know it's easy for us to diagnose CSR with OCT, but the presence of autofluorescence tells us about recent disease activity. So here you see a patient where the fluid amount is less, but the amount of autofluorescence is a much greater area, telling us that there was a lot of recent activity. The diagnosis between different types of CSR. In this patient, you see cystoid macular edema, while in the autofluorescence, you see extensive areas of without intermittent area being free. That tells us this is beyond a regular CSR, it's beyond multifocal CSR, and it's reached a stage where the RP is sick, and it's called the sick RP syndrome or a diffuse retinopigment epitheliopathy. This is another case where the progression of the disease from simple CSR to multifocal CSR to sick RP syndrome is well documented in these patients. Another patient where you have asymmetrical macular degeneration with a lot of dropout areas. The right eye and the left eye, you can now say that the visual acuity is going to be poorer, or the macula is going to be worse in the right eye, but the areas of hypoautofluorescence in the center. Again, differentiating Stargardt's disease with the flex being hyperautofluorescent and the macular atrophy areas being hypoautofluorescent. A marker of activity in certain diseases called serpiginous retinopathy. You can see that this is a patient who's undergone the disease and there's no active disease, there's no hyperautofluorescence. In a condition like this where you see a yellow spot in the center, and in the center you see an hyperautofluorescence, and this is an adult vitiliform degeneration patient. The next thing is that thou shalt not assume everything you see is fluid. A typical case of this would be mactal, where you have cystoid spaces. This is not cystoid macular edema. This is an area of an inner cystoid or inner reflective, hyperreflective lamellae. Again, in a vitiliform deposit where there's resorption of the deposit, it may look like subretinal fluid, but it is actually a resorption of the vitiliform material, and you can see it in this patient. Another condition where you see an area that looks like subretinal fluid, and this is a case of a torpedo maculopathy or a chorioretinal atrophy or dystrophy. This is another case of a torpedo maculopathy. Here you see a small elevation, and it could appear that it is fluid. This is a typical case of an outer retinal tubulation that happens on a dystrophic RP, a sign of a scar becoming established and the photoreceptors getting secluded above that. Thou shalt understand everything is not about just measuring the CFT. Biomarkers in DME include a lot of biomarkers, including drill, disruptions of the outer plexiform, the outer retinal health, the hyperreflective dots. So here you see what do you mean by drill? Drill is when the outer retinal layers are not, the inner retinal layers are not uniform and can be recognized. On the temporal side of the fovea, you see there's no differentiation between the inner retinal layers, and this is drill, disorganized retinal inner layers, and it's a key marker of visual acuity return after treatment of macular edema. So in this patient, you see there's edema, but after there's recovery, you can still see that the layers are distinct, and this could form a better prognosis against recurrence and all those things. Ellipsoid disruption, as we say, the outer retinal layers could be the keystone for having a good visual acuity. Here you see the ellipsoid zone is disrupted in these patients. Outer plexiform disruption is more when you see full thickness or full extensive cysts, and the outer plexiform layers, which are the vertical elements where take it out, you can see that they are disrupted, and that is a biomarker for poor visual acuity. Hyperreflective dots are macrophage containing lipids, which indicate a tendency to hard X-ray formation, a more inflammatory component of pathogenesis towards diabetic macular edema. parallelism of the retina. That is, when there is good parallelism, it means that the structure and relationship of the structure to each other is good. This is an example of good parallelism, and this is an example when the edema is too much, the layers are thrown into different segmentations, and you cannot identify the different layers amongst each other. So this is an example of poor visual acuity. There is more to ERMs and macular holes. This is an example of two surface pathologies. On the upper side, you see something called the LHEP, or the lamellar hole epiretinal proliferation. The lower is a tractional hole. So these are two types of lamellar holes. One is degenerative. The degenerative has a different appearance. The deeper layers are affected because it's degenerative, and you see a presence of an epiretinal proliferation, not tractional tissue. In a tractional hole, you see a surface tissue, and there's splitting of the retina, like you see the splitting of the inner layers of the retina in a mustache type pattern, and you see the retinal cystoid changes. So this is an example where you see both changes. You see the LHEP change, and you also see the tractional retinal change with the top hat pattern and also the skytic cystoid pattern. Thou shalt listen to what drusen tell you. There are different types of drusen. It's very interesting to know that each drusen is divided into different types based on the shape, the internal reflectivity. Here you can see concave drusen and convex drusen. The pointed ones are concave, and the rounded ones are convex. You see drusen which has a uniform interior. You see drusen which has heterogeneous interior. The drusen which has heterogeneous interior, and something that you see on the extreme right-hand corner are hyperreflective. So that's called a core. Drusen with core and drusen which are heterogeneous have a greater propensity to go to RP atrophy or geographic atrophy. So these are all the features you can see, and in these pictures you see all the time. You see homogeneous drusen, heterogeneous drusen, you see sawtooth drusen, and geographic atrophy. So these are just examples of what happens to drusen. You see a drusen exactly in the center with hyperreflective dots inside, and over time you see the nature change. That is, it becomes heterogeneous inside, and you see hyperreflective dots. These are all indicators of future or potential nascent or geographic atrophy happening. You should watch the RP carefully before it atrophies. So this is nascent geographic atrophy, where the subsidence or the layers move down towards the ellipsoid zone, you see, in that particular point. And that is because the vertical support of the photoreceptor support is lost. And just before this happens, you have changes where you see hyperreflective foci happening. Those are detached RPE cells leaving the RPE, and that's a precursor of diagnosing nascent geographic atrophy or RP atrophy. And again, whenever you have an RP atrophy, you have these vertical columns happening. Those are called sub-RP hyperreflective columns. Another evidence that the RP is about to atrophy before it goes to geographic atrophy. And this is a very consistent sign when you're evaluating geographic atrophy. So this is kind of I think a 12-year follow-up of a patient over years, and you can see all the changes, including hyperreflective foci happening, degeneration, adult vitelliform degeneration, and finally the patient goes into iRORA, which the hypertransmission increases and the geographic atrophy component increases. Thou shalt be knowledgeable of the different types of PEDs. So you have something called giant PEDs. We have huge locations have a feature of PCV and all those lesions. Extra large PEDs more than 1,000 microns are an indication for an imminent RIP or an imminent subretinal hemorrhage. These are called thumb-shaped PEDs, typical of PCV, like you see there. These are fibrovascular PEDs, where you see the vascular tissue right under the surface of the PEDs. This is called a multi-layered PED, where you see lamellae inside. It's kind of good prognostic, considered a good prognostic feature nowadays. And these are the lamellae you see inside the PEDs, and which is fibrosing effects. Again, this could be suggestive of a RAP lesion, where you see fibrovascular tissue underneath it and a small amount of SRF above it. Thou shalt know what to expect when the choroid is thickened. So pachychoroid is a flavor of the day now, where you see thickened pachy lesions. You have different forms, CSR being the most simple form. Pachychoroid geographic atrophy. You see pachydrusen with small amounts of fluid on the top of the surface. Peripapillary pachychoroid syndrome, where the thickness of the choroid is on the nasal thing, and you see cystoid changes rather than SRF on top of the papillomacular bundle. And this could eventually lead into having having a CNVM, a pachychoroid pigment epitheliopathy, where you have small changes which look like old CSR but can convert into up to PCV at a later date. When you see a double layer sign, you could always think that this could be harboring a neovascular process underneath it, and it could break into a frank SRF later. And this is what extensive filamentous membrane underneath the double layer sign could look like. And the last would be about OCT angiography, where you see making tremendous strides into diagnosing vascular networks, differentiating between type 1 and type 2 membranes. This is a typical type 1 membrane with a filamentous thin thing with thin capillary fringe-like, a Mactel patient in which you can differentiate the presence of a CNVM on the, just a couple of
Just
slides.
ignore it.
Yeah, sorry about that.
No problem.
Yeah, and even in the diagnosis of PCV on the angiography, you can see clearly the polyps. But on the OCT angiography, you can see a wonderful branching neovascular network. It might be a bit more difficult to see the polyps on the OCTA, but one of the main uses of the OCTA nowadays is establishing recurrence of CNVMs. Here you see a beautiful picture where you see a capillary fringe and an anastomotic membrane. This is a brilliant image of a capillary fringe where you see small capillary vessels in a recurrence, and you see anastomotic vessel going all around it. Again, the same theme. This is how a recurrence would look like, vessel running around it with small areas of budding. A patient which has on the temporal side, you have the capillary fringe happening, which tells you that this is a recurrence at that area. So just stuck over here. Yeah, just skip these. So when a CNVM fibroses or it goes away, it looks like this. It looks like a prune tree appearance. Only the big filamentous vessels and no small connecting vessels. And there are two patterns. One is called a skeletonization, in which you just see a frame, a broken framework of the whole neovascular membrane, and that tells you that it is nearly about to regress and go away. So the skeletonization and a fragmented vasculature is what you could be looking at, and it could be an indication for you to stop treatment. The last thing that the OCT has revealed is something called a non-exudative membrane. You see a small ripple or a double layer sign. There's no activity, but on the membrane, on an OCTA, you see a very faint blood vascular network. It is non-exudative. It's not yet reached exudation. And that is the thing. And the 10th commandment is that thou shalt respect the power of biomarkers. So there are many biomarkers in diabetic macular edema, some correlating with vision, some correlating with response to anti-VEGF, recovery of vision, systemic control, and disorganization. And there are a lot in AMD also, which regard to the progressive atrophy, the persistence, the recovery from anti-VEGF, the recovery after anti-VEGF and recurrences. And some of them, as we mentioned today, the whole talk was about those related to surgical retina, including IFL, about recovery, ellipsoid, the hypertransmission, the ELM defects and easy defects, macular hole, post-operative recovery in macular hole also. So thank you very much.